I'm Kjell Arne Johansson. I'm a professor at Bergen Centre for Ethics and Priorities in Health. I'm going to give you a mini lecture about ethical theories with relevance to priorities in health. We all have strong intuitions about what is right, what is wrong. Should we save old versus young? Should we prioritize disabilities or mortalities? On the other hand, we have ethical principles derived from comprehensive ethical theories, and this is maybe in conflict, maybe not. The overarching principle in many healthcare systems is the Aristotelian principle of equality. Equals should be treated equally and unequals unequally in proportion to their relevant differences. The question is, how does this apply in health? And how can we adhere to this principle when we're distributing scarce resources? At the clinical level, we have the four well-known principles: autonomy, beneficency, do no harm, fairness or justice. Our intuitions are more tuned at this level, so we can have intuitions on what is right when we have one patient in front of us, or two patients, maybe three. But when we get to a population level with huge populations, our intuitions crash. And then we need to rely on ethical principles to justify policies and decisions that we make. Maximizing health, priority to worst off, and financial risk protection are important principles at the population level, and you can see more about this in the film on principles and criteria for priorities in health. Theoretically, we have two dimensions of priority setting. We have procedural priority setting and we have substantive priority setting. At the procedural end, people will never agree if we're a large enough group. And how can we manage decisions that we need to make where everyone cannot agree? And then the theories of deliberative democracy can help us, and for health this has typically been developed in theories like accountability for reasonableness, where we have four minimum criteria of a fair process. We have some criteria supporting the relevance of what we can make, and we have some principles behind this. On the substantive issues in priority setting in health, I've tried to summarize thousands of meters of bookshelves of philosophical theory in one slide. On the left-hand side, you see the traditional ethical theories: utilitarianism, egalitarianism, prioritarianism, sufficientarianism, and the right-based approach. Typical principles are more the applied version of it. And theories, they need to have a coherent argument justifying every action, and then they have to be very abstract and are difficult to apply directly into decision making and priority setting in health. And these principles are derived from the theories and are more concrete but still open for interpretation. But then we have some quantitative tools that sort of support the ethical principles you see in the middle column here. So, for example, utilitarianism aim at maximizing health, and we can use health economic evaluations for that. Egalitarianism would always aim for equal distribution of health, and we could use typical inequality estimates. And these two principles may conflict, and that's where prioritarianism helps, because then we can trade off equal distribution and maximizing health. An example here would be, would you want to scale up a treatment in urban settings where you have a good infrastructure, less costly, you could save probably more lives, compared to scaling up an intervention in rural areas where you have to do much more investment in establishing the infrastructure? It would be more costly, and you would have a conflict between these two principles, and prioritarianism gives a solution for how you can balance these efficiency and equity trade-offs. Sufficientarianism is the typical threshold approach. You are concerned with everyone above a certain threshold. The problem is, what about those that are not above the threshold? You have the right-based approach, the human rights, and typically this could be institutionalized in the legislation. And here you see an example of how this has been institutionalized in Norway. We have four very important laws in Norway. We have the health service laws, patient and user rights, duties of healthcare personnel, and we have the special legislations, for example, for mental health care, when we need to violate the principle of autonomy sometimes because patients have reduced decisional capacity. Thank you very much.